Hi, I'm Erin,
Hi, I'm Jasmine.
and we did our project on the Laryngeal Web. So what is the Laryngeal Web? The Laryngeal Web is a rare organic voice disorder where a fibrous layer of tissue develops over the glottis and it obstructs the airway. So because your airway is obstructed, breathing will be difficult, but the severity depends on the length and the thickness of the web. So causes for a laryngeal web can either be congenital or acquired. So congenital means that it's there at birth because of the malformation of the larynx. So this malformation happens because an epithelial layer that's supposed to be eliminated at 10 weeks of development doesn't eliminate. So the web can either start anteriorly, posteriorly, or in a rare occasion, it could start posteriorly, go anteriorly. But for congenital, they start anteriorly most of the time. And the prevalence of congenital laryngeal webs is 1 in 10,000. So acquired causes for a laryngeal web can be gastroesophageal reflux, smoking, previous surgeries, infection, or a prolonged intubation. So as you can see, everything looks good. You could see both the left and the right vocal folds. You can see the subglottic region. Everything's pretty good. B, you cannot see the subglottic region at all. And the left and right vocal folds look like they're kind of just combined together, meshed together. And you could see your airway is a lot smaller than it was in picture A. So some physical and symptom signs to look out for is frequent shortness of breath, stridor voice, which is like a harsh vibrating sound because your airway is obstructed, poor feeding, and a weak cry. And for children, their symptoms may not be shown or present until the first few months of their lives. It's hard to find it in patients who have ventral laryngeal cleft, subglottic stenosis, or chromosomal or cardiovascular abnormalities, but it's something to keep in mind and to look out for. Symptoms could be wheezing, coughing, frequent chest infections, misdiagnosed asthma, or a constant raising of the head or lengthening the neck to try to get more airflow. So some acoustic signs to look out for babies is an abnormal, weak, or absent cry. But for general signs to look out for is vibration impairment, high pitch, rough voice, dysphonia, temporary loss of voice, or in an extreme case, aphonia, which is a complete or lack of voice.
All right, so there are 4 different types of anterior laryngeal webs, which develop in the anterior commissure of the glottis. And anterior webs are the most common type, and they comprise more than 95% of the cases of laryngeal webs. And like Erin said, there are posterior glottic webs, but those are extremely rare and only happen with acquired laryngeal webs. So the first type is a type 1 anomaly where the web only covers 35% or less of the glottis, and it usually presents in a thinner layer of webbing. So these aren't as severe. And infants with this type of webbing at the glottis may present no respiratory symptoms, but their cry might appear a bit hoarse. Moving on to a type 2 laryngeal web. This involves 35 to 50% of the glottis, where there may be subglottic extension from subglottic stenosis. And this is considered a profound narrowing of the airway below the vocal folds, affecting resonatory properties. So this type may cause mild airway symptoms and a weak cry for infants. Moving on to a type 3 laryngeal case. These webs involve 50 to 75% of the glottis, and these are usually thicker anteriorly and thinner posteriorly. And these patients will most likely have subglottic extension as well. And lastly, a patient with a type 4 would have the most severe case of webbing, where the webbing occupies 75 to 90% of the airway. And they are usually uniformly thick throughout with subglottic extension, and vocal cords actually may not even be identifiable with these types. So as you can see, a type 3 and type 4 webbing are the most severe cases of laryngeal webs, where the patients show more prominent symptoms like what Erin was talking about, and very little inspiratory and expiratory capacities. So laryngeal webs can be identified and diagnosed through instrumental assessment. So the most commonly used instrument would be a direct laryngoscopy. And these are long, thin instruments with a light and a lens or a small video camera at the end. And the laryngoscope is put in through your nose or your mouth, and it goes down your throat. And so the light at the end of the laryngoscopy will help the clinician observe the obvious anatomical anomalies pertaining strictly to laryngeal webs, but it can also be used to assess the severity of it so that we can figure out what treatment is best. So what will happen is the clinician will insert the laryngoscope and instruct the patient to produce a sound. Some things a clinician may look out for during this assessment would be the vibratory quality of the vocal folds, which can give us a sense for how thick the web is, the type of airway obstruction, and the color of the vocal folds. So these can all be signifying factors of what treatment is appropriate for the patient. And in some cases, it may also be necessary to perform a CT scan of the chest to look for any airway abnormalities that may co-occur with the symptoms of laryngeal webbing. But laryngoscopies are the main tool used for diagnosis and assessment. So here's a video of a laryngoscopy that was performed on a patient with a pretty severe laryngeal webbing. So. So here the clinician had the patient say the sound E, where it requires the vocal folds, the vocal fold vibration to have a strong airway supply to blow open the vocal folds, as well as the elastic feature of the vocal folds so that they have a good vibratory quality. And as you can see, there was little to no vibratory quality of the vocal folds. And this was also observed acoustically, as he sounded very weak and breathy and hoarse. In fact, the sound E wasn't even identifiable in this case. It sounded more like a glottal H sound, but with like little to no expiratory quality to it. So I think this patient was more of a type 3 laryngeal web with thicker layers of webbing. So moving on to treatment, the main goal for treatment is to remove the obstruction by breaking open the vocal folds, allowing the airway to open up to its full capacity. So it's always safety first. So depending on the severity of the web, the team of clinical experts, different treatments will be performed. So going from least invasive to invasive, a surgeon may choose treatment by dilating the trachea and using a laser to cut the instrument to break the web. So with this procedure, the surgeon will place a small balloon in the airway to widen or break the web. And this may be repeated to prevent reformation of the web by scar tissue. In addition to dilation, a surgeon may gear more towards using a CO2 laser to reconstruct the vocal folds. So after splitting open the vocal folds with the laser, the surgeon will put a stent or keel in to prevent the reoccurrence of webbing from post-operative tissue scarring. So using a laser is less invasive than an open surgery, and this may be only recommended to individuals who have mild webs. A surgeon may also recommend an open surgical approach to expand the airway. And for some webs, the correct treatment is an open surgical procedure called the laryngeal fissure, which is where the surgeon will open into the larynx, usually through a midline incision through the neck and through the thyroid cartilage, to reconstruct the vocal folds. So to separate the web, the surgeon will use a keel as well, like how we used in the laser, to maintain separation of the raw edges of the folds to avoid any reformation of the web caused by postoperative scarring. This will be recommended for more severe webbing and if they can foresee good postoperative outcomes. So for the laser and the laryngeal fissure, the keel is usually removed after a couple weeks. But for intervention at birth is where clinicians usually assess the severity of the webbing. So surgeons recommend that these treatments and open procedures to separate the laryngeal web to happen like when the child is around 4 years old, because the larynx will be larger and more developed, and which means that it'll be a less risky surgery, and they'll have better chances of having a better voice quality after surgery. So surgeons may not intervene in treatment until school age if the airway obstruction does not interfere with their safety. So this later intervention is usually only recommended for more mild webbing. For more severe webs, where their airway is the primary concern, early intervention is necessary. So that means that if the infant's airway is severely obstructed, a tracheostomy will be required at birth so the infant can breathe properly. So these children will then be reassessed when they're older, and treatment will depend on the thickness and the type of the webbing. Now, an open approach is usually warranted for thick glottal webs. So keeping the trach in after reassessment might be the most appropriate form of treatment. So moving on to prognosis, more specifically looking into the postoperative care after a laryngeal fissure, would require a patient to stay in the hospital for observation for about 1 to 2 nights post-op. And the team of clinical experts will look to see if the keel is still correctly in place and to see if there's any swelling or additional airway obstructions after surgery. Some complications for these treatments may include subcutaneous emphysema, infection, edema, growth of the epithelial tissue, and like I said, swelling. So the long-term prognosis is good for a normal lifespan, especially for these later interventions for the more mild webs. But some noticeable long-term symptoms may be a hoarse and a rough voice, depending on the severity of the webbing and postoperative care. So this is where an SLP can come in and help treat hoarseness and roughness of the voice by providing these patients with some breathing exercises to optimize intelligibility and a less strained vocal quality. So SLPs might also see patients with a laryngeal web who still have their trach in. So they could do a wide variety of therapy with these patients depending on their needs. But some therapy approaches may include swallowing, articulation, language, stuttering therapy, or patient and family education. So these patients may also benefit from AAC devices as well. Here we have some videos of voice quality and treatment options for patients with laryngeal webs. So the first video is of a school-age child. He's around 4 years old before he gets his laryngeal web surgery, and you can kind of hear his voice quality in that. So I'm gonna have Erin play that.
What's that? Wow. You want up? Yep.
Okay, so as you may have heard, his voice sounded very rough and hoarse. I'm expecting that in Lawrence's case that he had less severe laryngeal webbing at birth, which is why they recommended like the later intervention at school age for that web to be corrected. But you could still kind of hear his voice quality of how it's like a little bit rough and breathy. And so the next video is of a man, and he's in his 20s, and he had a more severe laryngeal web, and he had a trach for his whole life. This video, he explains that he has had multiple surgeries performed, but his voice quality is still not satisfactory. I think with this doctor, he opened up his airway a little bit. And as you can tell, his voice quality still isn't as clear, but he's now able to breathe through his nose after his trachea and the webbing were widened. So yeah, thank you for listening to our presentation. And I think now we can play like a Kahoot, where we have a couple questions for you guys. All right, I think Erin and I are going to log in.
Yes.
We better get these all right.
Embarrassing if we don't. Oh, look, we logged in at the same time. Perfect. Okay, ready?
Mm-hmm. Okay, a laryngeal web is a functional voice disorder, neurogenic, or organic voice disorder. It is an organic voice disorder. Good job, Erin.
Good job, Jasmine.
Laryngeal webs are most commonly known as acquired or congenital. They are most commonly known as congenital.
At the same time.
The main goal for treatment is to improve voice quality through voice therapy. There is no treatment, or to unblock the airway. The main goal for treatment is to unblock the airway because safety first. That is the most important thing that clinicians need to look out for. True or false? Laryngeal webs are very common. True or false? This is false. Laryngeal webs are extremely rare. Like we said, it's about, that didn't make sense, 1 in 10,000.
1,000.
Drum roll, please. Third place we have. Second place is me. Oh. Yay. Good job, Erin.
Good job, Jasmine.
Thank you for listening to our presentation, and we hope you have a nice day.
Bye. Thank you.